student webinar. We're up to number 43. Had some good questions come in recently for topic requests, and giving you a heads up that Thursday we'll be doing our public Q&A webinar, so make sure that you take some time to register for that. If you're one of our students or a student, it's a great way to get some free knowledge on topics that people have sent in. And again, this isn't just limited to students, of course, for our student webinars, but we try to focus on the student webinars, things that, you know, or if you're working on getting a credential, learning coding, and the subject that I picked for tonight was a great question. They were struggling with what's the difference between inpatient coding and outpatient coding. And it's true that if you get a standard core credential, you're probably going to be doing a lot of outpatient coding, and inpatient coding tends to be more of a specialty credential. Now, that isn't necessarily true across the board, but when someone talks about being a coder or getting a coding credential, usually they're, in my opinion, in my experience through the years, it's a lot of outpatient work. Inpatient is not a niche like risk adjustment or a specialty or like ER coding, things like that. It's not like that at all. However, there are just a lot more outpatient coders than there are inpatient coders. And in the past, still a little bit today, your inpatient coding tends to be a little harder to break into without having been a coder for a little while. So for the most part, if you talk to somebody and or you hear them say, "Hey, I'm a medical coder, what do you do?" or or you hear that that career path talked about, a lot of times it is an outpatient. They've spent a lot of time in outpatient coding. With that being said, then, what makes inpatient and outpatient coding different? Now, when we say inpatient, a lot of times it's inpatient. We're talking about inpatient facility coding, okay? So think about that. When a person's an inpatient coder, that means that there is a facility involved. But where you can get into some confusion is if you have a large hospital system, like here in my neck of the woods at this time, Baylor Scott and White is one of the larger hospital groups, and they have outpatient doctors as well. So even though they have hospitals all through this part of Texas, they're going to have outpatient clinics, and they'll have surgery centers and things like that. Now, I'm thinking of maybe when we lived in Missouri, Mercy was taking over a lot of different areas. So it was Mercy Hospital, but Mercy Hospital also had a subcategory of outpatient clinics. So if a person says, "Well, I work for, Baylor Scott and White as a coder," that doesn't necessarily mean that they're an inpatient coder, because every one of those doctors that are associated with Baylor Scott and White, by far more of them will be outpatient providers versus inpatient. Not that they don't have the ability to admit somebody in the hospital, it's just the fact that there's, if you are an inpatient provider like a hospitalist or something, that's all you do is the inpatient. A lot of radiologists, things like that, will be inpatient, will be part of the hospital. And then you'll notice too, when you go to apply for jobs, if, say, for example, again, Baylor Scott and White, if you're going to be a coder for them, they want to know, or you'll want to distinguish, is this going to be a facility position, facility coding, or will this be outpatient coding? And when you look at a big organization like that have many hospitals and many clinics across the state, then of course, they usually have multiple coders, but they code for large numbers. They won't have, a coder for all of the outpatient clinics in one town. No, they work as a team, and they may be doing all of Baylor Scott and White's coding, for example. And this is different wherever you go. There's little nuances and things, but for one, it depends how big the facility is, if they have clinics associated with them, and almost all of them do, or if they're independent providers, that would be considered outpatient. So let's talk about what is inpatient and what's outpatient definitions. Now, I just came up with this off of my head, but you can Google it, and the verbiage may be a little bit different, but this is the way I think of it. If it's going to be an inpatient, what constitutes inpatient? That means that a provider, a doctor, has written an order to admit you into the facility, okay? And you will stay there until the doctor discharges you. And that's usually when they've either figured out what the problem is, or they've been able to adequately treat whatever condition you have so that you can recover at home. So again, what makes it an inpatient stay is the fact that a provider writes an order and admits you into the hospital. And a little heads up, usually kind of a rule of thumb, and you'll literally hear them say rule of thumb, is that inpatient stays are over 24 hours. If you're going to be less than 24 hours, a lot of times it's called observation, or it's an outpatient stay in the hospital. So don't let that confuse you when we talk about what the definition of an outpatient is. And that's just anytime any provider is treating a patient. So what makes outpatient versus inpatient? The provider writes an order to admit you into the hospital for treatment, and then subsequently, if you're admitted, there'll be a discharge order as well. So if you're looking at documentation and you're not sure, those are definitely things that you'll see, but they could be admitted into observation, which is not an inpatient stay. It's a little bit different, right? They're just temporarily holding you in the hospital. They know they're making sure that you're recovering, or whatever treatment they've done, maybe in the ER, or they just need to run some tests, but you're not sick enough to stay and have the nurses and stuff take care of you for a long period of time. They just need to run tests, evaluate you, maybe even stabilize you enough that you can go home and recover on your own. Whereas with outpatient, you go and you see a provider, and then they send you home as soon as your visit's over, right? And there will be documentation, but there's not really doctor's orders per se. It's documentation of your visit, like an E&M, and then prescriptions or orders for tests could be done. Now, I'm trying to explain it from the viewpoint of maybe somebody that doesn't have as much medical background, so that you can kind of understand and get a feel for the verbiage, right? And everybody talks about it a little bit different, and it's not that we're lazy in the medical field. It's just that some of the words are really drawn out, and we always shorten everything. You'll notice that if this is new for you, an area, career for you. So, you're not going to have people say inpatient facility coding. They're just going to say inpatient coding and outpatient coding. Is this an outpatient or an inpatient job? Things like that. Some people might say facility, but I don't hear that verbiage as much as just inpatient and outpatient. So now you understand what the difference is. Let's talk about some of the different places that constitute inpatient care, because of course we think of a hospital. That's what, inpatient is, a hospital. However, there's actually some other areas that you might not have realized is inpatient facility. So the first one, again, inpatient, and there is acute and long-term hospitals. Now, when we talk about acute, that's probably what your I wouldn't say it's layman's, but what most people consider as a hospital. Let's say you fall down, you break your ankle, and you go into the ER. They admit you into the hospital because they need to do surgery. They do surgery, and 2 days later, you're sent home. Okay, that's acute. Now, long term. Inpatient would be someone, for example, that's going through a drug treatment program. So we're going to admit you as an inpatient, but it's because you're trying to um, uh, work with an addiction to heroin. Or maybe it's mental behavioral health. Okay, maybe you suffer from uh, bulimia. And so you're going in and you're getting treatment for that, or depression, or some other type of an illness that you're not acutely sick per se. We don't. However, you need to stay with this inpatient status. The doctor will write an order to admit you into the hospital for care. And don't think that it's something where someone's being forced to do this. No, they're writing an order to accept you into the hospital, not forcing you to go. But that's the difference between acute and long-term care hospitals. Then there's skilled nursing facilities, and that's pretty diverse within itself as well. Back a long time ago, or maybe if you're not as familiar with different verbiage, they're nursing homes. And we don't really say nursing home as much. I don't hear that verbiage as much as I used to, but I still, in the back of my mind, that's what I grew up knowing, it was the nursing home. And when I was in high school and had the opportunity to take some tech classes and stuff, and I did, I um, uh, became a certified nursing assistant. I got my CNA in my high school years, and because I knew that wherever I went to college, there was always a need for people to work in nursing homes. And just about wherever, any town large enough to have a college would have multiple nursing facilities there that I could get a job, or I could go get a job at the hospital. And so there, that's how I think of a nursing home, but that's technically a skilled nursing facility. So the skilled nursing facility could be something that is still temporary, in the fact that you don't need to stay there very long. Let's say that you fractured a hip, so you went into the ER, you stayed as an inpatient, you got the hip repaired, but it's not healed yet. And you live in an apartment complex on the second floor, and you are advanced in years, and maybe you have diabetes, and you're not going to be able to easily navigate or take care of yourself in this apartment. So they suggest that you become an inpatient at a skilled facility that's able to give you assistance. They have a special bathroom set up so that you can navigate with crutches or a walker, and physical therapy can come, so you don't have to go and do that. And you're going to be able to get your medication given to you by the facility staff, so that you don't get confused and accidentally take too much medication. Or they want to help you a little bit longer with your diabetes. Maybe the surgery, you had an infection after the surgery, and it messed up your diabetic sugar levels for a little while, and they just want to make sure that you're going to literally be able to navigate and get on your feet longer. There is not an age limit for skilled nursing facilities, although most people consider them a place for elderly, but it's not just for a specific age group. But there are facilities that are nursing homes that would be set up for an specific age group. When I was in college, I was working at a brand new skilled nursing facility right across from the college that I was attending, and I worked the 3 to 11 shift, and there was a young man that was in his 30s that was there, and his parents had set him up there because he had gotten sick, and he had mental issues and had a little bit of trouble navigating. He couldn't walk very well on his own, but anyway, he was there because it was a brand new, nice, clean facility, and they needed him to stay there for a short amount of time till he recovered, because they weren't able to take him home and care for themselves because they were more advanced in years. And so he was there for a month and lived there, and we took care of him. And then when they got everything ready for him to come home and he was in better health, he went home, and they went on with their lives. So it isn't necessarily a type of a facility. They have rehab centers too that would be a type of skilled nursing facility. There's a specific skill that's being provided for the people that are admitted. Often overlooked is hospice. Now, a long time ago, and mind you, I've been doing this for over 30 years, the hospice wasn't necessarily in the hospital. Back then there wasn't really hospice per se, that the way it is now. It is such a wonderful avenue that people can use for the end stages of life that just weren't available 30 and 40 years ago. And it's a specialty type of care in that you could be in a hospital or you could be in a facility that's a hospice center, and it's geared towards the comfort of the person that's at the end stages of their life and their families. So there is no visiting hour times. You can come and go and see your family member anytime. They're open pretty much 24 hours a day. And the nursing staff and the staff in general is set up to give comfort. And there's definitions for hospice to be able to be admitted into hospice care. Of course, same thing, you're going to get an order. Unlike inpatient, an acute facility, or even long term, there won't be a discharge order the same, but you would get admitted into hospice care and until the end stage of your life. And they aren't they still have standards and protocols and stuff, just like a hospital. It's set up a lot like a hospital, just much more comfortable for the patient and the family. But they have the ability to give care under a different protocol, like medications, pain medications. It's still regulated and controlled, but it's given to keep you comfortable. So the protocols and standards is a little bit different, and the nurses have a little more freedom in that. I have my roommate from college and a girl that I grew up with. She has, I guess, almost 30 years now for her too, but she has been a hospice social worker. That's what she specialized in. And she's still doing it to this day. And it's a very unique area of medicine, but it's still considered inpatient. You have to have an order putting you on hospice. And the other one that most people don't realize is home health. Even though it is not a facility, home health was created for people that it was difficult for them to get out for their visits. It was difficult for them to get care. They weren't sick enough to be in an acute facility or long term. They had a home, they had a caregiver that could take care of them, but the caregiver wouldn't be a clinician, but it was really difficult for the caregiver to get the person to their doctor visits and maybe physical therapy or occupational therapy. So let's go back and use the example of the patient that broke their hip. You know, you fracture your hip, you go into the ER, you're admitted from the ER into in an inpatient facility, an acute hospital. So the acute care hospital does the procedure on your hip, takes care of that, and then you'll be there in the acute facility until you're stable enough to either go to a long-term facility, or if you have caregivers, you can go home. And of course, it's not going to be easy to navigate, and you would need physical therapy. Let's say that you're diabetic. We'll use that example as well. And so your blood sugars are struggling because of the wound, the suture area for the repair of the hip. For a diabetic, might need extra wound care. Let's say they have an adhesion, and so let's say they put a wound vac on there to help promote the healing. And with all of that in tow, someone, well, your caregiver or your loved one might not be able to handle all of that on their own, or maybe there's education that needs to be done. So how we need to give education to this person to have for fall prevention. Let's say the reason they broke their hip was because they tripped on the corner of a rug that was in their house. So physical therapy comes in, and maybe the nutrition was poor because the patient was having trouble with their vision and decided to stop driving, and so they weren't eating properly or going out to the store. And so home health can help with all of that. They can get resources, the physical therapy, as well as having the clinicians, the nurses, come in, monitor the medication, not necessarily give you the medication, but give you training in your home, your own setting where you're more comfortable, and give suggestions like this pill planner would work better. Let me set up your pills for the week, and then I'll come back and check with you in the middle of the week and make sure that you understand. We'll check your vital signs. We'll double check your wound, and have PT, everybody come in to your home where you recover better than if you're in a facility, whether acute or long term, that has germs in it. And so home health is fabulous. Both hospice and home health are two areas of medicine that I think have been a real attribute to both patients and their families, so that people can stay at home. Thus, when I say hospice, if you're admitted into hospice, it's like a program. So you could be admitted into hospice. You have to have a doctor's order, and that usually states that, and I can't remember exactly the dates, but that, they don't expect you to live more than 8 months, or maybe it's a year. I can't remember. I think it's less than a year. Uh, you still could. However, that's, you're at the end stage. They're doing palliative care now. They're not able to cure you, or stop the progression of the disease process. So they want to keep you comfortable, and it can be done at home, but you're still written an order. So with every single one of those that we've listed here, from acute to long-term hospital to skilled nursing facility, hospice and home health, an order from a provider has to be written to admit you into one of these. And then, of course, you could be discharged. Very seldom you're not discharged from hospice, but you are discharged from home health, because home health is done like on a quarterly basis, like every 90 days. And if the nurse comes out, their caseworker, and evaluates you and says, you know what, I think we need to go for another 90 days. There's some other things that that's happening. So let's do, and these are my suggestions. This is what we need to do. Your physical therapy needs to be extended. We've had to now with your diabetes, you're going to be on insulin, and we want to do diabetic education and teach our patient how to work with insulin, how to inject themselves, and so on and so forth. And that can all be done in home versus having the patient go into the doctor's office. So, and then once the patient's stable and doing well on their own, then they're discharged from home health. Okay. So that is inpatient. Let's talk about outpatient. Now, of course, by far, outpatient is a much broader and diverse area. You're going to have the ER, your PCP, your provider that is your main provider that takes care of you, your PCP, is going to be considered outpatient. Ambulatory surgery centers, because you're not admitted to stay there. You will go in, have a procedure, and then you're sent home. And they still may use the term you're discharged to home, but that means that they're not sending you someplace else. Ambulatory surgery centers they do simple procedures. Maybe you can even go through an ambulatory surgery center for things like an appendectomy, if they don't do it through the main hospital, but I think they do. So ambulatory surgery centers are going to be things like EGDs, scopes, doing things on the joints, stuff that even if you have to stay several hours, you still will get sent home, that day or within a short amount of time. And then with outpatient, you have to consider the providers. You've got all kinds of specialties. So when you have a person decides to become a doctor, and they end up going through 8 years of school, 4 years of undergraduate, 4 years of graduate school, and then they usually go another 3 years for specialty. Even if you say you're going to be a general practitioner, there's a special that's kind of considered a specialty. So let's say you want to go into cardiology, and so you have a cardiologist. Now, the cardiologist will have privileges at the hospital and the facilities that we talked about. Okay, but they could admit you into the hospital and discharge you from the hospital, but they also have their own practice, and that would be considered outpatient. And pediatrics, of course, very, very common. And one that you might, the last three I added because you might not have been aware of them. Sleep studies. So there are sleep study centers. I was able to do my sleep study when we lived in Rochester, Minnesota. So it was at the Mayo Clinic, but it wasn't at the hospital. It was literally the Mayo Clinic, and they had a sleep study area. So you would go in, and this was all the clinics for all the specialties there. You would go in kind of late in the evening before they shut the doors down. They'd get you all set up. You would spend the night in the clinic, and because they had special rooms in this one, we went up, I think it was on like the third floor, and you went all the way over to the one side of the building, and they got you all signed in and stuff, and you had your little suitcase, and it takes about 30 minutes to get all your wires and everything glued to your head, and then they monitor you through the night and come in and talk to you, and and stuff, and maybe set you up on a CPAP and everything. And then the next morning they had a little snack area where they had like a continental type breakfast. So once they got everything taken off and done for you, you would go and eat, and then you would leave and go home. Okay, so 12 hours maybe you were in there, but that's still outpatient. You were not admitted into the hospital. It was a clinic. There's also pain clinics that you can go in and have studies done and treatment done. But again, it's considered outpatient. Pain clinics, you don't ever spend the night in a pain clinic like you would a sleep study, where it could get confusing. And the same thing with wound care. With wound care, several wound care places could be in the hospital, and they would have hyperbaric uh, chambers, so that you might go in and spend a few hours in the hyperbaric chamber. And again, you're not spending the night, but it's a longer amount of stay than you would be. And a lot of the times they're in the hospital because they have to be able to afford the electricity, or they're associated with the hospital. You get the idea. But that's the specialty type providers and outpatient. It's still a facility, right? Your pain clinic or your sleep study or the wound care clinic. There was even Coumadin clinics, which you're not allowed to say Coumadin clinic, you're supposed to say anticoagulant clinic, but that's all they did. They took care of people's medication when you're on Coumadin therapy. So you would come in, they would look at your levels, they would test your blood, and they would call the doctor, and then they would, regulate you. You might be on 2 milligrams of Coumadin 2 days a week, and 3 milligrams the other 5 days of the week, and vice versa. They had a little algorithm that they do for whatever your PTINR was and stuff. However, it's all considered outpatient. The only time you're inpatient is if you're admitted into, and all of these you might get a referral to the wound care clinic written, or the pain clinic, or an order to do a sleep study, but you're not admitted into a facility. And it gets confusing when you see the verbiage and you're reading it, and then when well, so and so went and had a sleep study, and they, gave him a gown and blah da 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 da, and isn't that inpatient? No. Well, there was an order. Well, yeah, there was an order for the sleep study, but not an order to admit you into the facility. And even when a person goes from an ER to they may not be admitted to the hospital, they may be admitted for observation. And then again, it's usually low. If it's less than 24 hours, very seldom is that considered an inpatient stay, if it's less than 24. Now, let's talk about the differences. And you can go to the link that I found this on when I was doing some research, to see if there was an easier way to explain this than me typing all of this stuff out. And this really, truly was a brilliant one. I appreciated the way they had divided this up. But the difference between physician and outpatient coding and facility inpatient coding, what are the main differences? It's really important to understand these because it may help you decide, where do I want to navigate my career? Right? Do I want to go and specialize in inpatient, or do I want to stay in outpatient? Facility and inpatient coding is not a niche, I would say, but however, it is a much smaller focus than what the opportunities that you have in outpatient, because it's just so diverse. It's not that you won't see a lot of different things come through as an inpatient, but we have to remember this is going to be much sicker people than outpatient would be, and yet outpatient has the possibility of everything, whereas inpatient, not as much. But with inpatient, you're talking about a lot more money involved with billing. The cost for a person to be inpatient is a lot higher than just about anything you're going to see in the outpatient setting. So the first thing is they definitely have in common is in the code sets, you're going to use ICD-10-CM in both, that code set for both inpatient and outpatient. And if you don't know, ICD-10 CM is our diagnoses. What's wrong with the patient? Do you have diabetes? Do you have that fractured hip? Do you have sleep apnea? Do you have difficulty walking? You have an abnormal gait? And I mean, these are things that maybe you would be admitted into home health, with an abnormal gait. So we have to educate and use physical therapy or OT, diagnoses and stuff. New diagnoses versus chronic conditions. All that's going to be captured in that code set. And then one of the main things that's different as you start to become educated in the code sets is the guidelines and the rules that if you're doing outpatient, you're not going to code probable, suspected, or ruled out conditions. You're going to code what the patient has, but everything else is just the provider thinking, it might be this, it might be that. Okay. So an example of that would be we're going to, the person has suspected pneumonia. They have a cough. They've had a persistent cough. They are coughing up phlegm. They have a fever. They have chills. And let's say they've been nauseated too. Now, and then the provider writes suspected pneumonia, shortness of breath. Those are all things that could be on there as that could be diagnoses, but it's suspected pneumonia, but they're going to send you over to the hospital to get a chest x-ray because they don't have a machine to do that in their office. So you cannot code that the patient has pneumonia because you don't know until you get the film back, which again, they don't do films anymore, dating myself. But until the x-ray, the radiologist says that, yeah, there's fluid in the left lung, that it's confirmed to pneumonia. Then with outpatient, you don't code the signs and symptoms, you code the pneumonia, right? But the provider may not know until the tests are back. It could be that way with lab work too. Say that you come in with all the signs and symptoms of diabetes and you have a family history of diabetes, and so the provider writes on there, we're going to rule out diabetes. I'm going to have you go do a glucose tolerance test, and then we'll see what that we'll run an HbA1c and find out what your blood sugars are when they do those testings, and that will confirm if you're a diabetic. So what are you going to code? Family history of diabetes, and then all the signs and symptoms. Now, one of the things about outpatient coding, as far as the learning curve goes, that means that if you don't know the disease process as well, maybe you don't know the signs and symptoms of diabetes, and there's like 15 or 20 signs and common signs and symptoms of diabetes, then you don't know not to code them. Let's go back to our pneumonia patient. Nausea really isn't a sign or symptom of pneumonia. Now, are they nauseous because they're coughing and they've got drainage? The phlegm is getting into their stomach. That could make you nauseous. Or maybe there's something else going on that's making them nauseous. Maybe it's a medication that they're taking that's making them nauseous. And so, but is it a sign and symptom of pneumonia? No. So you would code nausea, and then you would code the signs and symptoms of the pneumonia as well. Unlike an inpatient, it's different because an inpatient, you code everything. So if your patient comes in, let's say the patient's O2 stats are in the 70s and they have rapid respirations, they've got a fever, and they're diabetic, and the doctor is very concerned. So he calls the ambulance and has you admitted into the hospital with suspected pneumonia. So when you get over there, uh, he's probably listened and heard diminished lung sounds and things. And so, yeah, outpatient, he's still saying, I'm pretty sure you've got pneumonia, but regardless, you're too sick. You're not getting enough oxygen. So maybe it's not pneumonia, maybe it's some type of a respiratory failure, right? So we're definitely going to admit you into the hospital, and we're going to find out what's going on. And is it viral or bacterial pneumonia? If it is pneumonia, because that'll make a difference in the treatment. So all of those signs and symptoms get listed, as well as pneumonia. Okay, now that it kind of messes with people's heads when they first get into coding. It's like, well, how come in outpatient we don't do signs and symptoms? It's because you can pretty much always get a definitive diagnosis before they send you home. They're going to say something, right? Or they're going to have you come back to go over your tests, and they're going to come up with a diagnosis. Whereas with the facility, you're going to be coding everything, because it is the treatments that are going to be used will prove or disprove what you have. Whereas the outpatient, you're really getting reimbursed for what you do to the patient due to the diagnosis. Whereas inpatient, it's the diagnosis that's being reimbursed. So if you have all of these signs and symptoms and they think you have pneumonia, they know the hospital's going to be reimbursed for, $50,000 to treat a patient with pneumonia that has also diabetes, okay, versus 30,000 for just a person that has pneumonia and doesn't have diabetes, because we're going to have to do blood sugar tests. We're going to have to do a lot of extra treatments to a patient that has diabetes and pneumonia versus just pneumonia. Okay, so it's the behind the scenes as to why we do what we do for that. In addition, with outpatient, we use CPT and HCPCS codes. Now, HCPCS codes are used for Medicare patients, but CPT is the procedure codes, and that's what our reimbursement is based on via outpatient, because it's what we do to the patient, what the provider does to the patient due to the diagnosis. Unlike inpatient, we use ICD-10 PCS, and that is also for procedures. It's a completely different code set, but it's multi-axial. It's an amazing code set. And we're going to list everything that's done to the patient because of the diagnosis, but the diagnosis is how you're being reimbursed, okay? Reimbursement, again, shows you in the next block, primarily based on what the physician's getting paid for his services. Sometimes it's based on the insurance rates that the insurance, if you take Blue Cross Blue Shield, then the provider knows that when I see a new patient and they have 3 chronic conditions, I know I'm going to get X amount of dollars, $200 for that patient, versus a new patient that is just establishing care and needs a maintenance medication for hypertension. You're only going to get $100 for that patient. It's because that's what Blue Cross Blue Shield contracted out to pay you for, things like that. Ambulatory surgery rates, flat fees, things like that. But with inpatient, it's different because it's based on DRGs, and that's diagnosis related groups. Ultimately, when you break it down, it just means that if a patient comes in and they're going to have an appendectomy, they have appendicitis, okay, we know that it costs, $50,000 to treat a patient that's going to have that has acute appendicitis. And if their appendix ruptures before they take it out, then it's going to be $55,000. Okay, and it's all based on that diagnosis related group. It's all grouped in, and you get a lump sum. When you talk about physician pays, they don't require a hospital stay, whereas inpatient, 24 hours usually, at least 24 hours. The coding that's done is different as well. Not only are you using different code sets, we both use ICD-10, but CPT and HCPCS for outpatient, ICD-10 PCS for inpatient. The assignments for the codes are on individual encounters and visits. Okay, they don't carry over. You start over each time. So if a person comes in and the doctor determines that the patient has hypertension and they think that they might have diabetes, so they're going to rule out diabetes, you're going to code for the hypertension and the signs and symptoms that is for diabetes, and then they're going to come back and you're going to code for the hypertension again because they're saying, how you doing on your hypertension medication? And then if they confirm and give them a diagnosis of diabetes, then you're going to be able to code for that. Okay, so that encounter, if he doesn't address the hypertension, you don't code for the hypertension for the second visit. Right? Whereas the facility, it's all based on the length of stay, and you capture everything that happens during that length of stay. Okay, and we already know that it's going to be, usually more than 24 hours. So you can imagine what the difference would be for an appendectomy versus open heart surgery. Okay, that patient's going to be in for a very, very long time. The way that we bill out for outpatient versus inpatient is different as well, because we use the CMS 1500 form to submit claims in the outpatient world. You can go and just Google CMS 1500 and see what it looks like. Most people that are trained in coding are familiar with these forms because there's a billing aspect usually to your training. But definitely, if you're trained to be a biller, you're intensely tested and trained on these forms and the information and the content of these forms. So CMS 1500 forms, whereas for inpatient, it's a UB04 form. Now, when you look at them, several things of these forms are very, very similar because it's the patient data information, who they are, what their birthday is, where they live, where they work, was this a work-related injury, who their insurance company is, are they the card holder on the insurance company, all of this stuff that's all about getting paid is on there. And then your CMS 1500 form is going to list your diagnoses and your procedures, and then, but you only get like four or six spaces to do diagnoses, whereas the UB04 form is you can list like 25 diagnoses because we're being reimbursed via the diagnosis, not on the 1500 form. We need to know what the diagnosis is for medical decision making, but you're going to have your E&M codes on there and such, and maybe blood tests that were done, things. So again, two completely different areas of coding for the most part. If you can do outpatient coding, okay, if you're trained to be an outpatient coder, there are aspects of inpatient coding that you're taught, and you will definitely be able to be an inpatient coder. However, it is a different type of coding, because the rules, the behind the scenes are a little bit different. Why you code is different. But as an inpatient coder, the only thing as far as code sets are concerned is you would need to know how to use ICD-10 PCS, because outpatient coders use CPT and PCS. They're two completely different code sets. Okay. And the guidelines and rules are different. Now, if you are an inpatient coder and you want to start doing outpatient coding, that's a real learning curve, because ICD-10 PCS is it's a very easy to understand code set once you realize the minutia of it after you get it, but it's nothing like CPT. And CPT is not as black and white as PCS. There's a lot of gray area. CPT just isn't as good of a code set. So you're learning CPT is harder than learning PCS, I think, is what I'm trying to say. With that being said, if you're an inpatient coder and you have to rein in all of this information you've been doing for inpatient and change it to outpatient, sometimes I think that's a little harder than turning around and just learning a new code set from an outpatient perspective to do inpatient. So, you know, that both of them are unique. However, and they have diversity within their own means, but they are two separate types of coding. Your careers are different. Inpatient coders tend to get paid a little bit more than outpatient coders, but they tend to also hire for inpatient people who have coded for a little bit longer because, again, the documentation is much more extensive. It's not just one encounter at a time. It's very extensive. You could be looking at 1,000 pages, and it takes longer to code each individual person in inpatient than it does outpatient, and because outpatient usually is pretty quick, you know. So you might do 10 encounters, 10 inpatient versus 30 outpatient during your shift. And that's just kind of a guess, you know. Can they cross? Absolutely. But with inpatient, there's a lot more money involved. If you make an error, more, you know, a denial is going to cost the facility a whole lot of money. Whereas with outpatient, if there's a denial, yeah, it's going to cost, but again, you're doing 30 a day versus 10, you know, so just keeping it in perspective. Both are fascinating areas of coding. I know people that have done both and absolutely love both. You know, both give you very good CDI experience, documentation. You know, I think in inpatient, probably you learn a little faster with inpatient, the documentation and auditing versus outpatient if you're only working for one provider or something, you know. But again, great. Both of them are a lot of fun to do. If you really love ICD-10, inpatient is probably more in your realm. But if you love CPT, then maybe outpatient may be the way you want to go. But it doesn't matter. You can go back and forth. And if you are good at both or bring that knowledge base up in both, then man, nothing will stop you. What they call like a triple threat or something, a double threat. I don't know what they call that. So we've got some questions over here. Let me go ahead and get to those before. Let's see here. Shannon, if a child admitted to the PICU, which is like pediatric ICU, from an ER, is the CPT a critical care code? Age X, let's see, subsequent or initial, assuming it is a critical care code. Yeah. When a person's admitted into an ICU, usually they're going to be staying there, and but usually it's critical care. They don't put you in ICU, whether pediatric or not, without it being critical. There could be several reasons. My son was going to be admitted here several years back because he had a seizure that lasted over an hour, and they medicated him so much that they were stopping his respirations. And so he was going to be admitted into the pediatric ICU unit, but there was no beds. So he was admitted into the floor, the pediatric floor, and they brought in an off-duty PIC nurse, and she stayed and just literally stayed at the head of his bed all night. Well, he was not there. He didn't stay 24 hours because he recovered really, really quickly once all the drugs left him and everything. And so he was still admitted under observation, even though he would have been ICU if they'd been able to admit him. So it really matters depending. Yeah, you could use the CPT code, but ICUs are always associated to inpatient. So let's see. Shannon also said, a coding director instructed me to not code for suspected or probable cancers when our outpatient oncology specialist sees a patient in the hospital. Is that correct? Well, I can see why they're doing that. Cancer is a unique way of coding. You do not, and you said it was an oncologist specialist sees a patient in the hospital. Probable cancer. See, I'm going to read a little bit into this, and it may not be correct, but when you're in the hospital and the oncologist comes and sees the patient, is it because they already have cancer and they think that it's metastasized? Or is it because there's a mass and they're going to go in and they're going to biopsy the mass? And so again, it could be timing with that. Whenever you're dealing with you know, an inpatient setting. Why were they in the hospital to begin with? Is it because they had pneumonia? And then when they scanned them, they noticed that something was on the liver. And so the oncologist comes and talks to the patient about possible a tumor or a mass in the liver. Again, if their protocol was for you not to do it because they're the director, then don't do it. Okay. Uh, so with all the guidelines, we're to follow the guidelines. However, and especially if you're new as a student, you can question, well, why would I do that? And they can tell you, just don't do it, or do it this way. But they have protocols in place and stuff. And so it's like you learning Spanish and then telling a native person that speaks Spanish that they're saying me gusta wrong. It's like you don't, or going up to a doctor and say, and he says angina, and you were taught to say angina for chest pain. You don't correct them. Okay, so I would question the coding directors. How can we do that? And there's probably a reason why they do what they do, but uh, you can inpatient code for probable and stuff. However, is the person an inpatient or are they in observation? Because if they're in observation, they're not an inpatient, and it's coded different. Okay, so that's what I would say. I would have to, I would be leery to question somebody in an authoritative role without knowing all the answers or saying it directly. But there's nothing wrong with questioning. It's just don't do it as in I want to be educated. I want to know why we do this so that I don't make a mistake in the future. Escar says, would you code from the doctor assessment as a confirmed diagnosis? Yeah, you can. When they do the assessment is their diagnosis, the assessment and plan. So if you read everything and it kind of mentions that the patient has diabetes, but they're there because they have an upper respiratory infection, and you see that they take a diabetic medication, and when you get down here, but they didn't really per se address it, but then they say, upper respiratory infection and type 2 diabetes. And then the plan is to, they give them an antibiotic, da 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 da. Yeah, you code the diabetes, because honestly, things like diabetes affects every body system. They could give you a steroid for an upper respiratory infection, and if you're a diabetic, that is going to mess with your blood sugar. So they probably want you to check your blood sugars more frequently that week while you're on the steroids. So yeah. So yes, you would code from the assessment, which is the diagnosis. This is another word to say for the plan. Now, if you say HPI at the top, yeah, you can refer for that. But remember, there's all different types of coding. If you're doing risk adjustment, you're looking at the whole encounter. But for the most part, everything that you need is going to be there in the assessment or diagnosis, assessment and plan. And sometimes the information to get to a higher specificity is up in the note. Okay. You always want to code to the highest specificity. Escar said, the doctor, honestly, I admit the patient and then add the discharge next day. Would it be observation or inpatient? It's based on several things. One, how long they're in there. Can you be an inpatient and be less than 24 hours? Absolutely. It's based on what the provider says they did. I admitted the patient to observation. I admitted the patient into as an inpatient status. So if you're ever in doubt, you ask. But just as a rule of thumb, outpatient and observation is usually less than 24 hours, and and has a lot to do with money too. How especially like if it's Medicare or Medicaid, things like that, they won't pay. Um, you remember, whenever the government's involved, they're going to pay as the least amount they can, and so if they want to fight that this wasn't truly an inpatient stay, it was observation, they could. So there may be protocols wherever you're working that distinguishes that. Shannon says, discharge next day, page 18 of CPT, observation or inpatient care services, including admission and discharge services. Third paragraph, different date. C codes, right. And she's got the codes listed as 99217, 8 through 20 is 99224 through 6, and 992214. Very good. Absolutely. That is correct. Pam says, I'm an outpatient coder. 2, I've been coding for 6 years. Which credential do you recommend? Thanks, from North Carolina. Oh, the Carolinas are beautiful. Thank you for joining us, Pam. So if you've been outpatient and you've been doing that for 6 years, if you think you would like to get into inpatient, I would consider, depending on what credential you have, rules of thumb, you might want to go ahead and get your CCS. With your experience for 6 years, you could probably do it very easily. Just pick up your education in ICD-10 PCS, and the CCS is through AHIMA. The AAPC has the CIC credential. You could probably sit for that if you want. But if you've been an outpatient coder for that long, I'm going to assume that you already have your CPC or your COC. And the advantages of being duly credentialed, it does cost you more because you got to pay in to both organizations, but that diversity for employers, showing that you're duly credentialed, that you are a specialist with outpatient, but you also have the inpatient credential, the CCS, which is the most well-known inpatient credential, that goes pretty far. So I think I would, if I was in your situation, I think I'd go for the CCS. I'd look into that. Or maybe consider risk adjustment. Definitely the CRC is a lot of remote jobs. If you're wanting to work remote, then absolutely CRC would be where I would go. I try not to push CRC on everybody, but because it's my favorite credential. But it is a good one, and there's always need for risk adjustment now. Christine says, hospital patient on observation status, would you bill 99204 outpatient E&M instead of 99254 inpatient consultation? Well, it depends if it's a consultation or not, because a consultation has a specific criteria for it to be a consultation. So you do not code for a consultation unless it's truly a consultation. However, do know that Medicare doesn't pay for consultations. But you cannot code it as a consultation unless that's actually what it is. So you've got, let's see, a hospital patient on observation status, outpatient E&M instead of, you can't code one instead of the other just because you want to get paid, which I'm sure you know that. But consultations have that means they have asked a provider to come in and give their 2 cents because of their specialty. So if they're a pulmonologist, say you've got a patient that comes into observation and they want a pulmonologist to come in because they have pneumonia and they suspect the patient may have COPD, or patient may be COPD and they think they might be already into emphysema, et cetera, et cetera. So they call the pulmonologist to render their opinion, not take over care, but render their opinion. That's a consultation. Eddie, Glinda, I work for a hospital. Eddie, Glinda, Picardo, Korea, I can't roll my tongue. I work for a hospital. However, for the outpatient physician side, I code for the hospitalists that see the inpatients and the patients in observation status. How can I put, let me see. I lost it. Just 1 second here. Let me just move these over so I can look here instead. Sorry. I code for the hospitalists that see the inpatient patients and patients in observation status. How can I put this on my resume? Ooh, it's technically not inpatient coding, although patient is in hospital. Hopefully, yeah, it makes perfect sense. So your keyword right there is hospitalist. You want to put in your resume that you have coded for a hospitalist. And that carries a lot of weight. I remember when hospitalists first became a thing, and everyone was scrambling, was like, what do you mean you're a hospitalist? And if you don't know, if you're a student and you're joining us and you're just learning it, a hospitalist doesn't have their own practice. They're a doctor and they only work for the hospital. Okay. They specialize in working at the hospital. Okay. And so before, you had your providers that had their own practices, and they also worked at the hospital. They would do their rounds at the hospital. Now you have doctors that specialize in just working at the hospital. You don't see the hospitalist unless you're in the hospital. You don't follow up with the hospitalist. You may see the hospitalist that takes care of you and even does procedures and whatever, but once you're discharged, they don't see you again. Whereas before, whichever doctor you saw, you would follow up with that doctor afterwards, right? But I would use the key word you want is hospitalist, and you want to state that you have experience with inpatient and outpatient coding. But the hospitalist is the key word. That's great. That's excellent. Revisiting critical care code, subsequent or initial. Example of the difference, please. Okay, let me see if I can, let me see, Shannon, if I can do this on the top of my head. So forgive me if I tell you wrong. So your question was critical care, is it a subsequent or initial visit? So a person comes in, and they're critical care, then that means that they meet the criteria for critical care. Okay. Initial visit or initial means, again, the first time that they're being treated, right? Subsequent means when the doctor comes back to reevaluate them or make new orders to see how they're doing. Okay, for subsequent care. Hopefully that makes sense. That we've done some videos on that. So you might check our YouTube channel. And what I would do is just type in critical care. When you go to YouTube, Medical Coding Cert is our channel. And there's so many videos in there now, the thousands. And where you see the little looking glass, just type in critical care, and everything we've ever done on critical care will be in there. And I know we've done education on subsequent and initial, the two. But if you can't find anything, what I would suggest you do, Shannon, for me is do it as a topic request, or go to the forum, the CCO club, and just type that in, and I will give you some more information. I know there's some resources out there. I can't think of what they are off the top of my head, but I know that I've talked about this before, so I don't want to make a mistake and tell you something incorrect. But initial and subsequent throughout coding is something that gets very confusing. Funny Guy laughs when says, when you code a hospitalist pro fee charges, which ICD-2 ICD-10 guidelines do you follow, inpatient or outpatient? Well, if it's pro fee, it's outpatient. So yeah, you're gonna follow the outpatient guidelines, I would say. I really need a scenario to be able to tell you better. And plus, whenever you're dealing with a hospitalist, remember they're employees of the hospital. But just because you're an employee of the hospital doesn't mean that you're only doing inpatient, right? And so again, it really depends. What are you doing? Is the patient admitted as an inpatient or outpatient? You got to follow those guidelines. Grand Planner Central Station says, I work for a hospital, but for outpatient physician side, I code for a hospitalist that sees the inpatient patients and the patients in observation status. How can I put this on my resume? Oh, hopefully, because it's technically not inpatient coding. So that is, again, your keyword is hospitalist. That Again, let me back up. With a resume, and especially with you're sending them in electronically and stuff, whenever you are applying to a bigger organization, like my husband worked for TxDOT for a while, and he learned this while working there, is resumes are put on a point system whenever you work for like a government entity or anything like that. And they have to have keywords to be able to hit the point system. So outpatient is definitely a keyword. Inpatient's a keyword, but hospitalist is a keyword. And anybody that knows that you have coded for a hospitalist knows that you could have done inpatient, but they also do outpatient. So just the word hospitalist is going to be enough to garner the points that you need in there. There's a great organization we talked about the other day that does resume helps, and especially for coders. And so you might go back and look at some of our videos on YouTube, or go, if you're in the CCO club, you could go and look at that. You probably type in resume. And it was a great company. We met at the conference at HealthCon this last year in Vegas. You know, and they just charge, I think, a flat fee to help bring up your resume, and they know how, and they work with coders, so they know how to help you with your resume. And even if it's like $50 to get your resume in top shape, it's worth it. Let's see. So the ER patient that goes to critical care for the first time, their initial, or CR regardless if they were in the ER. Yeah, I think that's the way I would say it. Correct. It's not based on, remember, whenever you're doing critical care and it's the hospital, don't get CPT stuff confused with ICD. It's all about the diagnosis with the inpatient, okay? But you're talking about CPT codes because that's what you're doing with the ER. It would be initial. Yeah, the first time that they're treated, initial care, critical care, ER, right? Cynthia says, mature medical transcriptionist manager picked up my CPC and then restored my RHIT. Any words of wisdom in picking up a new job without specific coding experience for quite some years? Definitely go into risk adjustment. And, you know, you guys, if you are not already on LinkedIn, I would get on LinkedIn because it's going to be very advantageous to you to do that. There are tons of, I call them headhunters, but they're people looking for, you know, you've got a lot of good experience, even if you may not have done it for a while. But the fact that you have the RHIT and the CPC, it's going to be very beneficial to you. But risk adjustment is a very forgiving um, for new coders and for people getting back on track after being out. And let me tell you another place. Let me just look at my phone real quick because I'm on their group, and I want to tell you that they definitely go to Facebook and look up JFAMC. That's JFAMC. And they have a Facebook group. There's thousands of coders in there, but they do a lot of job placement helps. Okay, so if you're not already a part of that, that's networking that you I think it's abbreviated for Jobs for American Medical Coders. I think that's what that stands for, but it's JFAMC. I know several people that are in there. It's a very encouraging place to be. I don't spend a lot of time on Facebook. However, that's a place that I go in and peek around quite a bit. Yeah. Okay, let's see. One more. My job's so boring. I don't really code anything. The physicians code their own visits and the outpatient multi-special, blah, blah, blah. I basically verify. Hey, you know what? I'm sorry that that's boring, but that is, think of it this way. You're getting to read their documentation. You're building your skill set because of that. And, it's a great way to learn to be an auditor. And you're verifying that they're on track. You may find mistakes that you need to educate them on. So I'll tell you what, guys, we're running a little bit long. I appreciate all your questions. It's so much fun to do this for you. This is our student webinar. We also do a club webinar, which is more broad, and people with more experience are usually in there versus student. And then Thursday, we're doing our Q&A webinar, public webinar. Got some great topics already picked out for you. And go to the CCO.us website, go there and sign up, register for it. We appreciate you coming. If you have any questions that we didn't answer, just go to the CCO club and type in your questions, and we'll get to them this week for you. Okay? Thanks, guys. Thanks, Boyd. See you next time.